Hi, this is Julie Levinsky. I am the Associate Director of Digital for the Christopher Dana Reeve Foundation, and I'd like to welcome you all to this month's edition of our live chat with Nurse Linda. So Linda is a leader and provider of rehabilitation nursing for 40 years. She also writes the interactive Ask a Nurse blog, an evidence-based community forum on our online paralysis community. And every month we are lucky to have her live to answer your questions today. So now I'd like to turn it over to Linda. Hello, Linda.
Hi, Julie, and thank you. And welcome everyone to the webinar. It's always nice to spend an hour with you. So today I thought we would open with the topic of pressure injury. You might know them as pressure injury, pressure sore, decubitus ulcer, sitting sores. These are all different names that people use for pressure injury. Pressure injury is a term that's being used in healthcare right now today. However, it changes every minute, so we have to keep up with all the different names of pressure sores or pressure injuries because it changes, but we all know what we're talking about, those little sores that develop on people's skins from laying or having too much pressure on an area. This has been the subject of the blog this month, and so I'd like to open with a little bit more about pressure injuries, and then we have some very interesting and informative questions to answer towards the end of the session. So we will get to most of the questions, I do believe. So in talking about pressure injury, I put some pictures from the National Pressure Association, which is actually based out of Australia, but they have some wonderful graphics of pressure injuries. So I put those on the blog so you can refer back to those at different times and see what's happening to your body when you have a pressure injury. A pressure injury or pressure sore is quite a bit different than a regular bump or bruise or sore or even a surgical wound that you may have. Pressure injuries occur from pressure, which is usually from a bone pressing from the inside of your body down on your skin. The first thing you might see on the surface of your skin is a red spot or a darker color pigmentation. Pressure injuries usually come on places where a bone is close to the edge of the skin or there's a bony prominence, a pointy bone that is applying pressure from the inside of the body through the fat and muscle to the outer layer of the skin where you can actually see things. I think of pressure injuries much like an iceberg. When you see a little bit of red on the skin over a pressure injury, then you know that you've got some kind of damage in the cellular level of your body. And so when you see that red or darkly pigmented area of skin, you know that you see that little bit of a red spot, but inside your body there's a whole lot more going on. So it's like an iceberg. You see a little bit of ice on the top of the surface of the water, but there's a whole lot of ice below the surface of the water. And that's what a pressure injury is like. You see a little change in pigment on your skin, but what you can't see is all the changes that are going on underneath the skin. So when you see that little bit of red spot on your skin, you think, whoa, I need to stop right away and I need to tend to this and remove the pressure. So the bony prominence is probably the easiest one to see, is like on your elbow. So if you feel your elbow, you can feel that bone of your elbow right there, just real close. There's just like a thin layer of skin over that. Well, there are several places in your body where bones are close, or very pointy bones are putting pressure on the inside of your body, on the inside of your skin. So pressure sores don't develop on the outside of your body. They develop from the inside out. And so most often where people have problems with pressure injuries are on their two sides of their pelvis. So on each side of the pelvis there's a bone that sticks out. When you're sitting, that pressure is right on the center of your bottom, and that pressure of that pelvic bone is putting all your body weight through to that pressure on your skin. So as you're sitting, those tiny little capillaries will close off because there's too much pressure from your body for the force of the blood to get through those capillaries. So that's where it starts, is in the capillaries. And then as the blood gets turned off to that area because of pressure, more and more larger vessels will stop delivering blood to that area. So the tissue that's depending on the nutrients and the oxygen from that blood gets cut off. So those tissues get starved, and what will happen is they'll get damaged and they'll start to die in that particular area. So you need to remove the pressure right away. And that is the first thing. Even if you see a tiny little red spot, one of the best things to do is to stay off the area until that red spot goes away, because you don't know what's going on underneath the skin, and you want that blood flow to be able to return. So the two bones that come out of the pelvis where you're sitting, sometimes people will call them the sitting bones. The actual name for them is the ischia, and so the ischium when you're referring to two of them. And then another spot on your bottom is right at the top of the gluteal fold, more commonly known as the top of your butt. And so there's a bone right there at the sacrum where the last segment of the spine, of the bony spinal column is. It looks like a shield, and it's got a little pointy end to it. So when you're sitting, sometimes pressure is given on that sacrum. When you're laying down, you might have pressure on that sacrum. And then there's your two hip bones, one on each side of your body. And that's where we mostly see pressure injuries. But you can get pressure injury any place there's a bony prominence. So on the heel of your foot, if your shoe is fitting too tightly, or if you're doing some exercise and your shoe is rubbing your foot, you might get a pressure injury on your heel. When you're laying in bed, you might get pressure injury on either side of the bones that stick out on your ankle. You can see your ankle bones on each side of your foot. Even the tops of your toes. If you have a higher level injury, you might get a pressure injury on your shoulder blades or on your shoulders or on your elbows. If you wear splints to keep your hands positioned at night, if you have the strap too tight, you might get some little pressure injury on your knuckles. Sometimes people who lay on their back too long, and we see this a lot in the operating room, is that people will get a pressure injury right on the back of their head where you have that bone that protrudes on the back of a person's head. Sometimes people will get them on the little cartilage of their ear from laying on their side, or even down their spinal cord if they become very thin, or if they're a larger person, you might get little spots, a little line of spots going right down on your spine where the vertebrae are. Interestingly enough, a lot of times people who are very thin, you'll see more skin breakdown because there's not much protection there. But also people who are heavier will have an equal number of more skin breakdown, because a lot of times I'll hear people say, well, I don't need to do too much to protect my skin because I've got a lot of fat in there for protection. But fat is not a protectant for the bones. It really constricts the fluid, the blood from running through your vessels. So it acts as a constrictor because it flattens under the bony prominences. So being on either end of the spectrum, being with your underbody weight or overbody weight, is more of a risk factor for developing a pressure injury. What really helps your body cushion those bony prominences is muscle. And after spinal cord injury, people will find that their muscles have become smaller because they haven't been using them as much. So one of the things that we like to do to help prevent spinal cord injury is to provide exercise, which can be exercise from advanced therapies, or it can even be passive range of motion. So every time you're doing range of motion, you're helping to build your muscles, and you're helping to move that fluid around, get your blood circulating, reduce some of your edema, and build up your body to help protect yourself. Now, equipment is certainly available that will help you. So there's special seating materials, seating cushions, bed surfaces that you'll need to get to help protect your skin. You really want to stick with the medical equipment. It's expensive. Hopefully your payer will pay for this equipment. Typically they do. But you need to get the proper medical equipment to lay or sit, or even if you're sitting in your wheelchair and you have a wheelchair back that you're laying on or a headrest, you need to get the special pressure dispersing equipment, because that way the pressure is not so honed in exactly under that pointy bone, but it's spread out a little bit more. And so that takes some of the pressure away. However, there is no equipment that eliminates pressure. So a lot of times people get kind of lulled into this false security that if they're sitting on their pressure reducing equipment, that they don't need to do pressure releases because they're on the special equipment. But that's just absolutely not true. You still need to do your pressure releases at least every 10 to 15 minutes. Change your position in some way. You can kind of tilt yourself from one side of the chair to the other. If you have a power chair with a tilt button feature, you can use that. The best pressure release is actually to lift your body off of where you're sitting and let that circulation restart up again. When you sit back down, you'll be in a slightly different position. People who have sensation move their bodies all the time. We're just constantly in motion, little tiny tweaks, because as soon as you start to feel that pressure of those capillaries starting to close, you adjust your body just a little tiny bit. So if you don't have that ability to sense that, you have to accommodate for that. You can do your pressure releases by finding some kind of trigger in your life that will give you a time to do it. So commercials on TV, if you're watching a TV program, you'll notice that commercials come every 10 minutes. That's a good time to do a pressure release. Sometimes if you're in a work situation and you are in a busy office, every time you hear the phone ring, you can do a pressure release. You need to do them about every 10 minutes. You can certainly do them more often. It's helpful. You might be able to stretch it out to 15 minutes, but you really need to do your pressure releases no matter what. When you're in bed, you need to use that special surface. Now, sometimes people think, well, I can kind of get by cheaper if I get some foam or if I use a pillow to sit on. The foam that you get from, like around the house, the foam that's in your couch cushion, the foam that's in a desk chair, the foam that's in a pillow, those are not pressure dispersing. When you sit on that type of foam, the cellular construction of the foam is different than the medical grade foam. And so when you sit on that, you're creating more pressure because you're making a dense place where those bones are sitting or laying. And so it's just not a good idea to use anything except the accepted medical equipment. This is just one time that you just cannot scrimp and save. You have to use the regular equipment and you have to turn. The minute you see that you have a red spot or a darkened area, you need to stay off that area completely. That is the only way, is to remove the pressure. Don't apply any more pressure. Don't rub the area. That's just applying more pressure. So it's really to take the pressure away. And this is a huge patient dissatisfier, and I realize that, and I hear about it all the time because people will say, I cannot stay off my back or my side for a day because I have to, go to work or I have to do this, but I have other activities and commitments. However, if you allow that pressure sore to advance from just a red spot to actually opening and becoming a stage 2, stage 3, or stage 4 pressure injury, and then you're going to have to stay off of it for a longer period of time, because removing the pressure is about the only way that these sores heal. Now, some people will go to their healthcare provider, or they will go to a wound care specialist, and they will allow them to sit on the wounds for a certain amount of time. Remember that when you're sitting on that wound, you're taking away all the time that you have not been on that wound. You're restarting it all over again. So being off the wound is the only way to heal it. Some of the less deep wounds can heal up with less pressure, but still being able to sit for a moment or two. But it's really not recommended. The only way you can get those wounds to heal up is really to take the pressure off of them. Now, you can refer back to the blog and see what the different stages are. So stage 1 is just that red spot on the surface of the skin, but you'll see in the graphic that it goes way below the skin as well, where you cannot see. Stage 2 is an opening in the skin, so you might have a blister where it's not actually open to air, but the top layer of the skin has separated from the next layer of skin, and so there might be fluid in there, and you might see a blister, or it might just be the top layer of skin has been removed. If there's any opening, you'll want to clean and cover that wound, because if there's an opening, that means bacteria can get in. Stage 3 has gone a little bit deeper into the body, into the fat layer, and maybe into the muscle. Stage 4 is it's definitely down into the muscle. Sometimes you will see wounds that have you're not sure how deep they are, and we call these unstageable because they have this black eschar. You can almost think of it like a scab, but it doesn't really look like a scab. It's kind of that brownish color of a scab, but it's just some dead material that the body's trying to slough off. It might be eschar that's brown, or it might be kind of a white or greenish colored substance that's called slough, and that's the body trying to get rid of any debris or bacteria in there. If you have an open wound, you'd want to have it checked to make sure that you do not have an infection in that wound, because then you'll need to treat it. If it is a deep wound that goes deep into the skin, usually there's packing that involves, so you have to put some special gauze strips in there. Sometimes there's medication you put in there. Sometimes there's some ointment that you put in that helps remove the eschar and the slough, but you never want to use any kind of medication or packing without having the approval of your healthcare professional, because there's so much variability. You could have a pressure wound on one hip and then later a pressure wound on the other hip, and they could be completely different types of wounds. So be sure this is the time where you have to check with your healthcare professional every single time, and then keep off and remove the pressure altogether. Now, pressure injuries are much different from other injuries. So sometimes when you have an injury, what you want to do, just a regular injury, if you get a cut, if you have a surgical wound, what people will do, they'll sew up the surgical wound so the skin is closed. If you have a cut, you want to push the edges of the wound together so that bacteria, you want that skin to heal up at the top, the surface layer of the skin to heal up right away so that bacteria and infection does not get into the wound. Pressure injuries are exactly the opposite. You don't want the skin to heal up before the wound is healed from the bottom of the wound up. So you want to pack it to keep the wound actually open so that healing can come from the bottom up. Because of the way, and when you look at those little graphics of the picture, because the iceberg, there's a little bit of opening on the skin, on the top of the skin, but the wound itself will be much deeper and will be much wider than the opening at the top of the skin. Sometimes there's little tunnels that will work their way off from the gully of the wound, and so your healthcare professional will probe the wound. You want them to do this, not you, but they'll probe the wound to see if there's any tunneling so that they can pack that tunnel so, again, that it heals up from the bottom. Sometimes there's what's called undermining. So you might look at a wound, you can see into the wound, and you can see the bottom of the wound, but sometimes underneath there's some weakened tissue, and so that tissue is very fragile. Even though it looks like you can see the bottom of the wound, it actually is very fragile underneath there. So again, you have to pack these wounds. You have to treat them so that they heal from the inside of the body to the top layer of the skin. So it's a completely different process than what it's like for healing a regular wound. If the wound gets so deep that that bone is exposed or infection gets through the undermining to the bone, then you have an infection in your bone, and that has to be cleared up with antibiotics. You probably need to pack that wound and take, immaculately good care of that, because you don't want any infection in your bone, because then that can travel throughout your body. So you want to catch these wounds early, because number one, it's a lot less time to heal them when you catch them early, and number two, you don't want the wound to get so bad that you can get an infection in your bone and even become septic from a pressure ulcer. So, you just want to have these things healed up right away. If a wound becomes so bad or it's taking so long to heal, sometimes you might be referred to a surgeon, a specialty surgeon who takes out the debris of the wound, and then when they do surgery on these to heal the wounds, they'll actually take part of the muscle and move it over the bony prominence, so you have a little more muscle padding there, but they have to move the muscle, which is a bigger surgery, and then they will also have to rotate skin to cover the open area. So now they don't do surgery on little wounds, but when they get really big, they will do surgery, or if they're worried about bone infection, they might even have to go in and surgically remove part of your bone to clean that out. So we're talking, really delicate surgery. And then after you have surgery, there can be no pressure on that wound for 6 months. And then after the wound, and that's just a minimum, it might even be longer. And usually the doctor will have you sign maybe even a contract with him so that you can put no pressure on that surgical wound, because it'll just burst right open. And then the next surgery has to be more extensive. So this is the hard time when you get these pressure. That's why you want to get them treated early so you don't have to do this. Now, once you've had a pressure injury, a scar forms. Anytime you have an injury to your skin, a scar forms. And scars are not elastic like regular body tissue. So that tissue is far more fragile. So once you have a pressure injury, you have to take even more, you have to take better care. You have to pay more attention to it than you did before. So if you think you're doing a lot of pressure releases now, you will be doing even more after pressure injury. So this is, as I say, this is very dissatisfying, because it cuts people out of their life. They're stuck in their bed, and oh boy, after somebody's had a surgery, they're always like, I will never do this again. Now, you can do everything possible. You can do everything right. You can eat right. You can drink a lot of fluids. You can be doing your pressure releases. Maybe you've gone for a while with not one single pressure sore, but as our bodies age, our skin becomes less elastic. So it's the kind of thing, as you get older, you have to be even more vigilant about these pressure sores. So this is one of those things where, it's like this is where the rubber hits the road. There's just no room for much wiggle room in these pressure sores. So anything you can do to help yourself, watching your diet, drinking fluids, doing your pressure releases. If you smoke, when you smoke, when you vape, If you use electronic cigarettes, you're putting substances into your body. Now, I know cigarettes have nicotine, and people will say, well, I vape and that doesn't have nicotine. But it has other substances that are entering your lungs. And when the nicotine enters your lungs, it binds to those red blood cells. So nicotine is there and not the oxygen that needs to bind to those. So if you're smoking, you've got yourself set up for decreased circulation, and you just are giving yourself a pressure injury. So be very careful with that. Anything that you inhale, you're taking oxygen away from your red blood cells. So just, keep that all clean. So very important kinds of things to think about. So we'll step away from pressure injuries for a moment because we have some really great questions going on. And we have a lady here who's written in, who's 25 years old, from Algeria. And, she'd like for me to speak French. Unfortunately, I cannot. But however, you can go onto the Christopher and Dana Reeve website. There are booklets about skin care, bowel and bladder care, spasticity, and there are also wallet cards that you can take to your healthcare professional if you're in a pinch and you think you have autonomic dysreflexia. There's a whole listing of pamphlets, and they are printed in various languages. So if you go onto the website and look for educational materials, you will find that you will have just about any language that you need. So that will be helpful. We have a person who's 19 years old who's been paraplegic for almost 2 years. Talking about a standing frame, he does not have PT anymore. So standing frames, in the United States, you need to get a prescription. You can buy some directly, but you need to have somebody work with you on the standing frame. First of all, you need to have your healthcare professional assess the person to make sure that they're able to stand. So sometimes people have a bony injury, or maybe they've had a contraction, or they have some kind of skeletal problem that needs to be resolved before standing can occur. The other thing is, as everybody will recall, after traumatic spinal cord injury, people have a very difficult time with managing their blood pressure. So they have what we call orthostatic hypotension, which means that when you elevate your head, you get a little bit faint. Sometimes people actually pass out when they're just trying to sit up immediately after an injury. And so it takes a little bit of practice to learn to sit up again. So sometimes if you've been in a chair for almost 2 years or laying in bed for almost 2 years, if you stand up in a standing frame, you're going to just pass right out. So you need to work with somebody who can help evaluate your blood pressure to make sure that you're healthy, that your heart's able to produce the blood to get to your head when you make that transition. You might need to wear elastic hose when you're in the standing frame. You might need to wear an abdominal binder. You might need to drink extra fluids before you get up to build up your blood volume. So you can get up in that standing frame. So you shouldn't just do this on your own. You really need to have somebody help you. You also need to look at positioning, because talking about skin care, when you're in the standing frame, there's a strap that goes across your knees so they don't buckle and you don't fall down. And there's one that will go across your hips, and maybe, depending on your level, you might need one for your chest. And so any place where your body bends, there will be a strap. So whereas you didn't ever have any pressure on your knees before, now all of a sudden there's pressure because that strap's holding your knees there, or on your hip bones, on your pelvic bones, and more towards the front of your body. You've not had pressure there before, so that skin can break down really easily. So you have to start skin tolerance with that. So maybe you only stand up in the standing frame maybe for 5 minutes, and then you need to get down and check your skin in these pressure areas. So getting in the standing frame takes a lot of help and education to see how those work. Now, there are also standing frames if you have a lower level injury that are like gliders, like skiing. So if you see those exercise machines that have the arm sticks so that you can move your arms, they have standing frames so that if you're able to move your arm, it will also move your leg at the same time. So you can get some motion with that as well. So talk to your healthcare professional. They can order them. They can write a letter of medical necessity to your payer, and oftentimes you can get those covered. So there's a lot of things with standing frames. It seems like, oh, okay, well, we'll just get in one of these and go. But there's a lot of things to consider with that, with blood pressure and skin care and all those sort of things. The next question is, how important is a schedule for individuals with spinal cord injury? As this person's daughter has a new SCI. Well, schedules are very important, and for a lot of people, I know myself, I have a schedule for like when I go to work, but other than that, I don't schedule like my personal body functions. I just go to the toilet when I feel like I have to go. I eat when I feel like I need to eat. I move without thinking because my body tells me, and it just becomes second nature. But it's important for bowel, bladder, and skin care to have a schedule. You don't want your bladder to get over-distended, nor do you want your bladder to be catheterizing so often that you introduce an infection. So people usually cath between every 3 to 4 hours, but they have to monitor how much they drink so their bladder does not get over-distended. Monitoring how much you drink, because if you're drinking alcohol or caffeine products, your bladder is going to fill faster, and so you have to monitor those kinds of things. Bowel programs should be done at a minimum of every other day. That's usually where people start. Some people like to do the bowel program every day. They feel more secure. Very few people can put it off for every 3 days. You don't say how old your daughter is, but I can tell you that teenagers do not care for these kinds of schedules. It's not the way they live. It's not the way their culture is in the teenage years. So it's very important to stick to a schedule for those kinds of things. Also for your skin to do those pressure releases, because we just talked about how important that is. So following a schedule for those bodily functions is the way that you are going to be thinking. It becomes second nature after a while. Sometimes people will start their bladder training and they drink so much fluid every hour while they're awake so that they can gauge how they're putting out their urine. But most like everybody, we all get into little habits. So everybody goes to the bathroom to urinate first thing in the morning. Then you might go like maybe mid-morning. Sometimes because you're at work and you don't have time to go at other times, people might go to the bathroom at lunchtime. Some people follow a regular schedule for their bowel. Their bowels move at a certain time every day, maybe after they eat certain kinds of foods, certainly after ingesting that morning fluid, or if you're having a cup of coffee in the morning. A lot of people evacuate their bowels at that time. Other people are not so regular, and they just go when they feel like they have to go. To avoid accidents or to avoid any kind of bladder trouble, you don't want that urine to back up into the kidneys. So to avoid any kind of complications, you have to evacuate your bowel and bladder on a schedule. However, once you get into a daily routine, which everybody pretty much has a routine with work or school, then it pretty much works into some kind of routine. So depending on how old your daughter is, she'll be maybe more amenable to this, but developing a routine for bodily functions is going to be very, very critical. So this lady writes in that she's had transverse myelitis since 2012, and she's being able to do some things that she was not able to do before. And you will find that with the nervous system will have some recovery no matter what. Now, some diseases are progressive, and so the disease might progress more quickly than the recovery comes. But diseases like transverse myelitis, if you're not familiar with that, that is a process that happens where people have an infection or something happens to their body, and because of illness, they have some paralysis. Sometimes the recovery will happen with that disease, and so it sounds like this is what's happening, is that the nervous system is always trying to repair itself. It's a very slow process, but the nervous system is trying to recover just like every other part of your body, or it's rerouting messages. So the nervous system will develop new nerve cells very, very slowly, but also the messages that are getting through to the body, if they can't go one direction, they'll try and take another direction. This has been demonstrated with the functional MRI tests. In fact, Christopher Reeve was one of the first people to demonstrate that his body was remapping his brain, so different parts of his brain was making parts of his body work. So it was working around the spinal cord injury, which was really neat to see. So that's what's happening to this lady. So she's having some recovery, and she'll continue to have recovery. You need to move your body. If you are looking for nervous system recovery, you need to have movement, and that certainly helps. One of the great things that's going on now is all the different scientific research that's going on to help people recover quicker. And so there's some experimental procedures that are being done that are showing great promise with some nerve implants. And the Christopher and Dana Reeve Paralysis Foundation has been instrumental in helping scientists with funding and to support their research. And so they're making great strides. Now, I think that all of this is wonderful, and I know that people enjoy hearing about it, but every day that you're a person that's in a chair is like a day too long that you have to wait. And people are always talking about great scientific breakthroughs, and there's still people sitting in chairs. But at this point in time, the science is moving at lightning fast speed. So I think we're going to be seeing a lot of results coming out in the next few years. There's a lot of scientists all over the world working on different projects. And so we're seeing and we're benefiting a lot. And a lot of this work stemmed from the work with Christopher Reeve. So what a giant he was to have the heroism to try the activity-based therapies and to just, basically be a guinea pig for all people with spinal cord injury. So a very brave person who really changed the face of spinal cord injury treatment. So we have a lot of great things that are going on. So we have a lot of hope and things to look forward to. Another person is concerned about the invasiveness of their son's bowel routine. Is once per week okay, and do they need to clear the bowels before using the suppository because the suppository is not working well, and it's been 2 years? Well, first of all, most people do their bowel routine every other day. Once a week is not enough to evacuate the bowels because that's storing a lot of stool. The bowel has capacity, the large intestine has a lot of capacity for storing stool. That's where it is housed right before it comes out. However, if it stays in there too long, the large intestine is constantly taking water out of whatever is in the large intestine. So if stool stays in there too long, it gets drier and drier, and the more you put in there and the drier it gets, the more it's going to build up in there until it becomes really hard, and then the bowel's not able to push it out. The bowel's not able to push out. It needs a moist stool to be able to push it out. So you should talk to your healthcare professional. I'm not sure where you are, if you're in the United States or the developed nations, there are places where you can go to talk to people about bowel programs. Another great help, as I said earlier, is to check in with some of these booklets. We'll give you some educational background for why we do things the way we do them. But basically, what we do is we use a suppository every other day. Now, you're saying the suppository is not working. He doesn't seem to respond to it. Check your technique or his technique for how the suppository is inserted, because if the suppository is just placed directly straight into the rectum, it's probably being placed in the middle of all this stool. It will not melt there. It will not work there. When you put the suppository in, you have to gently guide it to the side of the bowel. Put it up as far as you can and gently guide it so it's laying up against the wall of the bowel. When it melts there, that triggers the bowel to work. Now, there are several different kinds of suppositories. Most people start out with what's called a brand name Ducalox, but you can get any kind of bisicotal suppository. And that's usually what people start out with. There's one that has the same active ingredient that's called the Magic Bullet. Now, some people love the Ducalox, some people love the Magic Bullet kind. The only difference really between them is the coating. So the Magic Bullet is has a vegetable coating on it, so it melts faster. And so a lot of people like that because it shortens their bowel program. The Ducalox suppository has a different kind of coating. It takes a little bit longer to dissolve. Now, some people like that for other reasons. They like to put it in, and then they know that they have a predictable amount of time to get to the toilet. So it just is personal preference, what you would really prefer to use. Now, there are other suppositories called glycerin suppositories. Those are much, much more gentle. So if you're using the glycerin suppository, it might not be strong enough for your son. You might want to use the Ducalox or the Magic Bullet type of suppository. Now, the reason why I say to put it in as far as you can in the rectum is because there's an external sphincter to your rectum, which you can see. That's the opening to the rectum. And so you can see that one. But up in the bowel, there's an internal sphincter. And so you need to get the suppository up in past that internal sphincter, because that's where it's really going to work in that part of the bowel that's going to be contracting to push the stool out. And the suppository will make that stool contract. Now, we don't really recommend any kind of enemas for bowel cleaning, because it works way up higher in the bowel, and so the bowel gets lazy. It stops its contraction because what happens is you're just washing out the stool, and so eventually the bowel gets lazy and it doesn't want to work anymore. So we want the bowel to work as normally as possible, so that's why we use the suppositories. Now, after you put the suppository in, you wait about 10 or 15 minutes, and then with a lubricated glove finger, so you have a glove on and lots of lubricant, you can place a finger in the rectum and very gently swirl around. Again, you want to feel if you can get your finger in there as far as you can so you dilate that inner sphincter, because a lot of times if a person has spasms, it has spasmed close, and that's why the suppository is not working. Maybe the bowel's working, but maybe there's a spasm in that sphincter, and that's why the stool's not coming out. Could be any of these reasons. So if you dilate that sphincter, then the stool will come out. You might need to do digital stimulation 2 times, 10 minutes apart. But if you do this every other day, the bowel gets into routine. You need to do it at the same time every day. I was going to say the exact same time, but you can be a half an hour off or so, and that doesn't matter. But if you're going to do it like at 8 o'clock at night, then do it at 8 o'clock at night. If you do it in the morning, you can do it in the morning at 7 a.m. Whatever time is the time that you know is going to be consistent that you're going to be able to do the suppository. It's not the kind of thing when you're training the bowel to work It's not the kind of thing where you can do it morning today and we'll do it in the evening in a couple of days. You have to do it at the same time because you're getting the bowel into a regimented routine. Another thing is to be sure and eat foods full of fiber. You might need to take some fiber. People mostly do not take laxatives because they're unpredictable and sometimes they work long after the bowel program would be completed, and so there's a lot of accidents with those. Now, if you want to add fiber, there's something called bulk forming laxative. It works in a completely different way. It's like you'll see Citracil, Metamucil. There's a lot of these different brands of fiber, and they're also unfortunately called laxatives because they are laxatives, but they're more predictable. Another thing, there's something called the mini enema. It's usually branded under enemies. Some people will use that. It's a small amount of fluid and it only works in the lower bowel, so you're not washing out that whole bowel. So there's a lot of different options, so you want to talk to your healthcare professional. A suppository is a medication, so you'll want to talk to your doctor about adding any medication. So suppository is a medication, and they would be able to direct you to the right strength if you need the Ducalox, the Magic Bullet, or if you need a glycerin. You know, they'll be able to help you figure out what that's supposed to be. Another thing that's very helpful with emptying the bowels that's often overlooked is gravity. If your person can sit up on a commode chair and have the bowel movement while sitting, gravity, you know, brings things down to earth, so it helps pull that stool out of the body. So that's another important thing. Be sure and drink lots of fluids because you don't want to keep that bowel hydrated. And so after a while, it might take a while, but after a while you'll get that suppository to work and you'll get that bowel program going. Another question is, how is recurrent UTI post 4 years with self-voiding possible? Well, UTI is possible at any time for anybody if you have a spinal cord injury or not. So, you know, even though you're doing self-voiding and not catheterizing, I think, you know, what you're saying is that you're not introducing infection with catheterization, which certainly you have a higher risk with doing catheterization, but you know, a lot of people catheterize and they don't get infections as well. Sometimes it's what the person is doing. So with self-voiding, and you know, you're very fortunate that you're able to self-void. Sometimes people maybe only self-void like maybe 2 times a day, like in the morning and in the evening. So you need to void a little bit more than that. When the urine is collected in the bladder and it's sitting there and it's stagnant, it's not moving around. So if you're not moving your abdomen by walking or doing other kinds of activity, it's just sitting there in the bladder. So if you have any type of bacteria that gets in through, I don't know, through other areas of your body and, you know, any fluids being excreted through your bladder, so that bacteria can get in there through the urethra where the urine comes out, or it can get in there because the body's eliminating the bacteria from other parts of your body. So, and if you're not emptying that bladder frequently enough, then that bacteria sits in there, it starts multiplying. If it gets up against the bowel wall, it's where it really loves to live and flourish, unfortunately. If it's floating around and it's just 1 or 2 bacteria, it's not really going to do anything, but it can be floating around. If it's floating in there for too long, it starts multiplying. If it gets up against the bladder wall, it's multiplying even faster. If you're drinking sugary drinks, sodas with sugar, or the athletic drinks that are ever so popular now, they have a lot of sugar in them. Or if you're drinking a lot of coffee with sugar, other things, if you're putting sugar in drinks like iced teas or something, that bacteria loves that. It seems to me like people who have one infection and they take antibiotics, the urine comes out clear, you could still be harboring one or two bacteria in your bladder that's kind of hiding in there that doesn't come up in a lab test. And so what happens then is that starts to multiply, but it might take a while before it gets going. So it might be really the same bacteria in there. But if you're self-voiding, be sure that you do that frequently enough. Be sure you're drinking enough so that you're flushing out your bladder a lot. So you should, while awake, you should be toileting about every 4 hours and making sure you have enough fluid in there to get that bladder completely emptied. You might want to check and see if your bladder is completely emptying. Maybe some urine is lingering behind, so you might want to have urodynamic testing to see what's going on. Maybe, or they even have that bladder scanner where you can empty your bladder, and then it's just like a little ultrasound. They could do it right there in the doctor's office. Put the wand over your abdomen and see if there's any urine left behind, because if you're not emptying completely, that's giving that urine time to stay stagnant in your bladder again. So those are some of the reasons. I don't know the reason why you're having the UTIs with self-voiding, but those are all the reasons why it could be, and so there are a lot of them. So, it's just the kind of thing that some people are more prone to UTIs than other people are. Certainly the movement, and if you're not emptying your bladder completely. The next question is, have you seen recovery in patients who've had incomplete spinal cord injury in the C4T1 area? I'm numb but have sensation, but have a lot of spasm and muscle tone. Do you recommend anything for nerve healing? Well, the one thing that we do know is that activity seems to help individuals with spinal cord injury through all kinds of things. Bladder infection, like we just talked about, being able to evacuate the bowels that we talked about earlier, skin care, helps your lungs, helps your breathing, helps your circulation. So probably activity is probably the best thing that you can provide for your body. Now, people who have spasm and have some muscle tone, sometimes that will help provide activity as well. Oftentimes that becomes so painful, and you say you still have some sensation, that people will get treatment for that to quiet that muscle tone, which is totally appropriate kind of thing to do because you cannot live in pain. But if you can harness some of that spasticity, that will help provide some activity to your body. If you don't have that, or if you need to control your spasms because of pain, you can do passive range of motion, and that will help. If you can get involved in any of the activity-based recovery treatments, that certainly will help as well. Here's a great question. I have a good friend who's a quad, and we'd like to know if it's possible for him to have sex. Well, yes, it is. Now, again, there are medications. You all have heard, because it's on TV every 2 minutes, about Viagra, Cialis. There's some injectable medication that you can use that will help produce an erection for a man. For a woman, there's not anything that is a drug that can be used to help increase sexual function in the genitalia. But for men, there's a whole lot of different medications. There's electrical stimulation that will help produce an erection. It will not produce an ejaculation, though. So sometimes people get frustrated with that. Because of sensation issues, they might not feel an orgasm as they felt before. However, sex is 80% psychological. So sometimes people, if they are willing and open and have a partner or would like to use self-exploration and are able to think about sex, and you can sometimes produce a orgasm-like sensation in your mind. Some people have sex and they find it pleasurable, but don't reach the orgasmic state. Sometimes people will not use their genitalia, but if they have sensation like in their armpit, they might be able to use that, especially women might be able to use that as an alternate to the vagina because they have sensation there. So there's a variety of things for sexual function. So is it possible to have sex? Why, yes, it is. You'll probably have to use some kind of medical stimulation, but then the ejaculation and orgasm would be different than what would be known to be. Now, some people find that they have sex with the medications and they just adapt right to it and they're perfectly satisfied. It all depends on how open you are, using sexual exploitation to increase foreplay by stimulating different parts of the body, and that seems to help. But, you just really need to try it and see what works for you and how it's working, and to be open to different possibilities. So having an understanding partner is a very important possibility with that. So good luck on that one. And there are people who specialize in this area. You can also contact the peer support group. People who, there are quadriplegic individuals with quadriplegia, individuals with paraplegia, lower level people with lower level injuries that don't have the tone, the spasm part of the sexual response. So there's all kinds of different possibilities, and there's a lot of frank discussion there, so you can get ideas from other people as well. Now I know you don't want to just, like go up to somebody and say, how are you doing it? But if you go on to something like the peer support group, they'll connect you with people who are willing and have had this experience and will help you. Those are just some brief ideas. I have a blog. If you go back in the blog and search for sex, there's some more ideas and some more detail about that. So let's see. I think we have time for one more question. And let's see. Oh, here's a real good one. We'll end where we started. So if healing from a pressure wound in the sacral area, is it okay to sit in a cardiac chair so it can be tilted? Well, that is a great idea because tilting can help, but whenever you're sitting or lying on your back, you're putting pressure on the sacral area. That is a back area. That's a place where we consider a back area. Now, cardiac chairs are usually lined with foam, but they're not usually lined with the medical grade foam. So if you decide to use a cardiac chair, you're still going to be putting pressure on your sacrum. But if you decide to use a cardiac chair and you're able to get in and out of that, or somebody can help you in and out of that chair, be sure and use your pressure dispersing mattress on that. If you have a sacral area wound, you'll need to stay off of that to get that healed up. So I'm trying to think. I have seen some wedges put into people's wheelchairs, which will tilt them off that sacral area, but then you have to watch your hips because you're putting more pressure on your hips than you normally do with sitting. So you can check with physical therapist or healthcare provider, or even a dealer, a wheelchair dealer, to see if there's any way that you can get that pressure off the sacral area. Sometimes there are cutouts, but you have to be very careful with those because sometimes people in years past have used things like donuts, which just is a round constrictor to that sacral area. So you don't want to use anything like that. But because it's in the sacral area, if you have support to the back and support to your thighs, sometimes they can create a little window in there, a little bridge, if you will, so that you can sit. And that would probably be the best bet, is to look at seating material to see if you can open up that sacral area. The sacrum is kind of a tricky spot, especially for pressure injury, because not only are you putting pressure when you're sitting or when you're laying on your back, you're putting pressure right on that sacrum. But it's also what we call a dark, warm, moist area, because it's so near the rectum. The rectum produces gas. It's like the book that kids have, Everybody Poops. And so there's constant emissions from the rectal area. It can also get moist if you're a female from the genitalia area, or if you're a male or female and have urinary incontinence, that area gets wet. It's a dark area. That's where moisture likes to breed, and that's where when the skin gets wet, it breaks down more easily, especially with the gases from the rectum, or if stool remains there. I don't know why it would, but sometimes people have a little leakage or something. So probably the best bet would be to look at the seating system and create a little bridge so that your ischias are still on your seating surface and your back is still on the seating surface, but there's a little opening right there at the back so that you're not having any pressure on that. So with that kind of convoluted explanation, but that seems to be the best thing to do. With that, it brings us to the top of the hour, and I think we've answered pretty much everyone's question today. So if you have any future questions, be sure and write into the blog, and we'll get your question answered as quickly as possible. Thanks for tuning in today.
Thanks, Linda. Thanks, everyone, for joining us. And this will be posted, this recorded presentation will be posted on our YouTube channel by the end of the week. Thanks a lot.
That does conclude our conference for today. Thank you for your participation. You may disconnect.